Good morning and welcome to your Vasopressor Bootcamp, Part 2. Today we are talking about which vasopressors are true vasopressors, which ones are more of inotropes, and which ones are both, or neither. So let's get into it. This is a great chart to help us understand what our vasopressors are doing so that we can, from there, match that to the physiology of the shock state. So, starting off with our most common vasopressor, norepinephrine, we know that this hits the alpha and beta receptors, so it's going to have a lot of squeeze in those vessels and cause vasoconstriction, but it's also going to have some inotropic effects by hitting those beta 1 receptors, so it's going to increase the blood pressure and the heart rate. Next up, we've got epinephrine. So epinephrine hits the beta receptors a little bit more than norepinephrine and hits the alpha receptors a little bit less than norepinephrine. So we're going to move it towards the inotropic side and down on the vasopressor side. So a little bit better for heart rate and not as good for blood pressure, but still has a pretty good vasoconstricting effect. Next up, we've got dopamine, which we don't use very often anymore. And if we do use it, we should make sure it's at high enough doses to have a vasopressor and inotropic effect. So at high doses, we can see dopamine having a similar effect to norepinephrine and epinephrine, but it doesn't cause quite as much vasoconstriction and not quite as much inotropy. Moving on to our pure vasoconstrictors, phenylephrine and vasopressin. So phenylephrine and vasopressin are pure vasoconstrictors because they don't have any inotropic effect. So they're not hitting beta receptors in the heart. They're not causing that increase in inotropy. Phenylephrine is purely hitting the alpha 1 receptor, so it only causes vasoconstriction, and you actually might see some reflex bradycardia from these agents. So if that is a concern, it's very important that you are combining these with your other vasopressors that have inotropic effect. Vasopressin, again, hits those vasopressin receptors and is just working on the vasculature to constrict those vessels. Then we have our agents that are more so inotropes. So these are going to be Dobutamine and Milrinone. These ones are going to increase inotropy and actually decrease the blood pressure, so decrease that vasoconstrictive effect. So keeping that in mind, when we're picking our vasopressor, depending on our shock state, we'll understand if we need vasoconstrictive effect, inotropic effect, or both. This is a really important concept to grasp. So follow along. Next video, we're going to talk about norepinephrine, how to dose it, when to pick it, when to not pick it. All right, that's what I got for you guys. Bye.